Good afternoon. I'm Darrell West, Vice President of Government Studies and Director of the Center for Technology Innovation here at the Brookings Institution. And I'd like to welcome you to today's forum on mobile medical devices. And this is part of our mobile economy project sponsored by Qualcomm. And we are webcasting this event live. We've set up a Twitter feed at hashtag TechCTI. That's TechCTI. So if you wish to post comments or ask any questions, you can feel free to do so through that. We will be having a question and answer session following our opening remarks, so we will take questions both from our live as well as virtual audience. So there's been an explosion of mobile medical devices. At the consumer level, there are calorie counters, my personal favorite, the exercise trackers, and prescription reminders. But then we're also seeing instruments that display the electrical signal from your heart rate, electrical activity in the brain, blood glucose levels, and sounds coming from your arteries and veins. These are very helpful to healthcare professionals because they can provide early warning signs of serious problems. I was in China a few months ago, and while there, visited a medical clinic where physicians were monitoring patient symptoms. There were a number of different patients for whom they had remote monitoring devices. Those electronic readings would come into this medical center, and there were a number of physicians that were monitoring those readings in real time. And they told us that in 20% of the cases, they found abnormal readings. And then they would refer that individual for further medical evaluation. And I think this is the type of proactive medical care that is great for patients and great for the medical system because it can provide an early indication of problems that might be very serious. So there are a lot of exciting new applications that are coming online. There are many experiments and innovations taking place, both in the United States as well as around the world. Today's event is going to focus on improving healthcare through mobile medical devices and sensors. We obviously face many challenges in the healthcare area. This includes issues of access, affordability, and quality delivery. But the good news is that mobile technology can help on many of those issues. For example, remote monitoring devices can improve the delivery of care. Mobile sensors can help bridge the rural-urban divide that exists in many countries. And mobile devices offer new ways to connect patients with their healthcare providers. Today, we are putting out a paper on mobile medical devices. We provide examples of some of the cool things that are happening in the healthcare area. There are a number of very interesting innovations in the diagnosis of health problems. There's been a proliferation of sensors and remote monitoring tools. And we discuss some of the policy changes needed in order to facilitate mobile health innovation. So if you didn't pick up a copy, we have them out in the hallway right outside the auditorium. To help us understand this topic, we've assembled a number of distinguished experts. Eric Augustin is Program Director of the Tobacco Control Research Branch of the Cancer Control Division of the National Cancer Institute. He holds a doctorate in clinical psychology from the University of New Mexico and a master's of public health degree from Johns Hopkins with a focus on epidemiology. His research focuses on health behaviors and hardcore smoking and how to deal with that issue. He has over 40 publications and has made more than 100 professional presentations. He directs NCI's smoking cessation websites such as smokefree.gov and women.smokefree.gov. Iltafat Hussain is founder and editor-in-chief of imedicalapps.com. He is a second-year emergency medicine resident physician at Wake Forest University at its School of Medicine. He has a master's in he is a master's of public health candidate at the University of North Carolina School of Public Health. He's writing a thesis focused on the affordability of electronic health records in an ambulatory setting. And he's very interested in how mobile technology can improve the physician-patient relationship. Asif Khan is CEO of CareMerge. This is a company that focuses on solving communication and care coordination challenges facing senior citizens in particular. This is a demographic that has more chronic illnesses, costs the most in terms of health care, and has the greatest number of providers involved in their individual care. Prior to forming this company, he served in several senior and global product marketing roles at GE Healthcare. So I'm going to start with Eric. You work in the medical area. What are some of the key issues in using mHealth as an intervention platform?
Well, thank you, Daryl. And I want to thank the conference organizers for inviting me to be with you here today.
That would be me, by the way.
Okay, well, thank you. I think I'm required by law to make a statement that says something like, even though I am from the National Cancer Institute, nothing I say today should be interpreted as the official stance of the National Cancer Institute or the Department of Health and Human Services in any way. Okay, so got that out of the way. I think I'm also required to say smoking is bad, and so now we've taken care of that. So, as Daryl mentioned, I am the director of smokefree.gov, which is a very large eHealth and mHealth initiative that NCI has been the point on. And this now encompasses 4 different websites, about 7, maybe 8, I've actually lost track, text message programs, half a dozen smartphone apps, and well over a dozen social media platforms. The function of this entire program as a whole is designed to deliver behavioral interventions via eHealth and mHealth resources. So our interest from its very onset, and this is actually our 10th year anniversary, from its very onset, we have never approached this as a dissemination tool, but specifically as an intervention tool. And that has been where our focus has been. The challenges that I see 4 challenges that we're facing right now within this field. And although I'll be talking about these as challenges from an interventionist perspective, I think that these are equally true for everyone in this room, no matter how you are touching these technologies. So these technologies have obviously become very important to us, very integrated in our lives. And so I'm not going to ask for a show of hands, but be honest with yourself. For how many of you would you be more panicked if you forgot to say goodbye to your loved one this morning, or you forgot your phone at home this morning? Again, no show of hands, okay? So the challenges, I think, come down to this. The first of these has to do with health literacy. We are now capable of collecting so much data in real time that we can create these massive databases. But then what do we do with those? It's very easy to get enamored with our ability to collect data, but ultimately we have to be able to crunch that data down into something meaningful, whether that is data that's going to a medical team, which will have much more sophistication than the audiences that I reach out to, which are the actual end users. And keep in mind that the individuals who carry the greatest health burden in this country are the people who are least likely to have health literacy. These people don't understand the numbers that their doctor is giving them. How are they going to understand the numbers that we are creating with our massive data sets? So health literacy, I think, is our first challenge. The second is, are we in fact reaching our target populations? And Daryl actually alluded to this just a moment ago when he was talking about some of his favorite apps. So I'm a runner. I love my running apps. I actually have like 3 or 4 places I track them, okay? I'm probably not your target audience for a diet or physical activity intervention. I run marathons, which you wouldn't necessarily know to look at me, okay? But again, I am embracing these technologies full on, but I'm not who we need to be reaching. So, and again, it becomes very easy to get enamored with, oh, 5 million people have downloaded this particular piece of technology. But how many of those people actually needed a health behavior intervention? The third challenge I think we face has to do with the sustainability of behavior change. So again, as an interventionist, I'm focused on behavior change. We are very, very good, despite what you might read or hear from behavioral scientists, mostly because we are our own worst enemies. But we're actually very good at initiating behavior change and getting it to sustain for short periods of time. We are not that good at getting it to extend over long periods of time. And so this then becomes a place where we can actually use these technologies, but to date we haven't really done them very well. And this is a fascinating place where the intersection of some of the basic, what we know about human behavior and the psychological interventions and the psychological literature come very nicely in intersection with the technology which is emerging. So how can we use that functionality to help sustain behavior change? And then the other side of that is how can we take more sophisticated psychological approaches to how we prime the appropriate motivation to sustain behavior change? Now, I'm very, very lucky. I have a colleague who's actually here today, Dr. Heather Patrick. Heather, go ahead and raise your hand. I won't make you stand up. So Heather is an expert in priming motivation to sustain behavior change. And so she's recently come on to my team and will be serving a very important role in new initiatives that we'll be rolling out within the next 18 months or so, which are really going to be trying to address this issue of sustainable behavior change. The last point I want to make has to do with evaluation. How do we know these things work? We have, and so now I'm going to put on my NIH researcher hat, keeping in mind that nothing I say is an official, okay, right. But as a researcher, the models that I was trained in take multiple years to answer big questions about the effectiveness of an intervention. That is not feasible, not tenable in the space that we are all working. In the time that it would take me to initiate a large-scale RTC, large-scale randomized clinical trial, and then collect 12-month follow-up data, so recruit all those people, treat all those people, that's the time frame in which basically the iPhone has existed. That's what we're talking about. So I would launch an assessment program that by the time I came to the end and my results were published, I'd be dealing with a technology that was so out of date that how could it be relevant? So there is a real tension that is going on between the conservatism of research approaches, our standard research approaches, and the very entrepreneurial and dynamic nature of the space that we are in the using mHealth and eHealth kinds of interventions. We have not yet effectively found a way to blend those two, to come to the middle space where we can both be doing solid, methodologically rigorous evaluations while also recognizing the dynamicness and the rapidly changing field that we're in. And I will stop there.
Okay, thank you. So, Ilford, developers put together new medical applications and you review them on your website. What are the most promising mobile medical tools or applications that you are seeing?
Okay, so and at iMedical Labs, we review medical devices and mainly focus on mobile applications as well. I think my fellow panelists mentioned something very interesting about how the research yet maybe isn't being intertwined with the devices that are being produced as well. And I hope we talk about that some more later, but some of the standard ones that a lot of people know about are blood pressure monitors. We have glucometers as well. So these can be done wirelessly. So you can take your blood sugar reading and wirelessly upload it to your iPhone. You can take your blood pressure cuff, put it on your phone, connect it to your iPhone or Android device, and you can trend out your blood pressure levels, go to your doctor's office, and they're able to see where your blood pressure is, and they can titrate accordingly. Two devices that I'm really interested in, and over the past year have been getting a lot of buzz. And full disclosure, I don't have any sort of financial or vested interest in any of these devices, unfortunately. But so I always say that, especially from anytime we talk, we have to give a full disclosure. But one of them are smart pill bottles. So you have AdhereTech, which is a really interesting company that is using these smart pill bottles to essentially see if patients are compliant with their medication or not. And you can put your pills in the smart pill bottle that will determine if how many pills you have left, determine if you open up the pill bottle or not, if you took the medication, and it'll actually send patients text messages to let them know, hey, you need to make sure you're taking this medication. That's tremendously important because medical adherence it's a really big issue, and patients who are non-compliant end up costing us billions of dollars in the healthcare system. I see it on a daily basis. I'll see it in patients who come in and because their blood pressure is just completely out of control. It's led to them having a stroke, or I'll see it in patients who come in essentially a diabetic coma because they weren't taking their medications appropriately. So I think tackling those types of devices that tackle diseases that have a high burden, I think are very, very interesting, very intriguing, and I think are game changers. One other one that's really interesting is VisiMobile by Sotera Wireless. This is just recently got FDA approval and is getting a lot of buzz. And this device can actually passively measure all your vital signs. So it can measure your blood pressure, it can measure your heart rate, it can measure your pulse oximetry, and also your overall telemetry, so your heart rhythm. I think it's really interesting. It does it in a non-passive way. It does it in a very passive way. I think that's very important. When we review devices, we've noticed, and you've probably seen this as well, one of the biggest barriers is getting, if you can do things in a passive way without the patient having to necessarily initiate things, you can collect a lot more data, and you can get more consistent data as well. And I think it has a lot of hope in the ambulatory setting and also the inpatient setting because of how easy it is to use. But saying all this, I say this with an important caveat that just because we can monitor vital signs and other things doesn't necessarily mean we should, and doesn't necessarily mean that it leads to better outcomes. I'll give you, I won't call out companies specifically, but we're starting to see this emergence of baby monitoring devices is how they call them. So these types of devices will monitor children's pulse oximetry, their heart rate as well. And that's not necessarily a good thing. We have literature, I'll give you an example. Bronchiolitis is a type of viral infection that affects, a lot of toddlers. And, they come into my ER and the child is not breathing well. It's a self-limiting type of disease, lasts 3 to 4 days. And we'll put them on the pulse oximetry. We'll see, their oxygen levels are a little low. We're going to admit them to the hospital. And we'll put them on a monitor, trend them out, see where their oxygen levels are, see if they need any supplemental oxygen as well. But in 2004, a pretty big study came out that said when you continuously monitor these children, they actually have longer hospital stays. So we should only be intermittently monitoring their pulse oximetry. So the sequela of having a longer hospital stay, for a child can lead to worse outcomes. So just because we can monitor, just because we can collect this data, it's not necessarily a good thing. So we need to be very careful in which populations we decide to monitor vital signs in which populations we determine are high risk, right? Just because we can do it, doesn't necessarily mean we should. I hope some of the other things that we talk about are going to be incentivizing physicians to use this data too. There's data that shows that slightly over 50% of patient visits can be done virtually, or through e-visits, or through emails, or through communication. So what is going to incentivize a patient to digitally communicate with their patients? I think that's something that as a society we need to figure out. And as a society, we need to figure out if we're willing to change the fundamental physician-patient relationship. Oftentimes, we say we're using all these modern techniques, we want our physicians to use it, but as a society, are we willing to say, instead of every 3 to 4 months, you have to go to your doctor to get your blood pressure taken to see where your blood pressure levels are and to get your medication titrated, are we willing to say, you know what, you don't need to do those 3 to 4 month visits. Instead, your doctor can virtually just see where your blood pressure is trending, where, if you're having any other symptoms or sequelae of high blood pressure, and they can just virtually send you a message that says, okay, you need to double up on your blood pressure medication, or hey, you can decrease some of your blood pressure medication. Are we willing to do that as a society? I think that's going to be interesting, especially with the new influx in patients that we're getting, because I'll tell you what, we can't just throw more primary care doctors on it. They're not coming. We keep talking about how we need more primary care doctors. It's not going to come, so we have to figure out how to do things more efficiently.
Okay, Asif, you focus on healthcare for the elderly. So how do mobile devices enable healthcare for senior citizens?
Right, so what we do is our solutions are not used by the elderly. It's actually used by the people who are providing care for them. So like you mentioned earlier, as we grow old, we have the most chronic illnesses, we cost the most to healthcare, and we have a lot of providers, just around us providing care, and hopefully they're talking to each other, but realistically we know that doesn't happen. So to Iltifat's point, I think earlier, we're at a point in time where we have to kind of understand what is doctor-patient relationship, how that's going to change. With respect to elder care, we provide our services, and I'll kind of round out to why I identified Dr. Fat's point, is there are lots of elderly in senior living communities, for example, right? Lots of providers outside of those communities, a lot of family members who make the decisions for them. And the demand on primary care physicians or just any physicians or nurses is increasing with 30+ million people, like Iltafat mentioned, accessing healthcare system now. So that demand is very high. According to Pew Research, there are 10,000 people reaching age 65 every day in the United States for the next 17 years. So when you talk about the demand and the patient-physician relationship, I think we don't have a choice. I mean, we have to figure out ways to get the right information at the right time about the right patient, to the right provider, so they can make the right choices and just move on. Having said that, I think one of the things that we focus on at CareMerge is providing tools for these providers and family members so they can just press a button and capture information quickly. And we have algorithms in the back to automate a lot of communication among them. So if somebody has fallen, they tag, press a button. Information is then, text messages go to the director of nursing, to the family members, whoever is involved. So now everybody's in the loop very quickly, and effectively rather than a lot of phone calls that go back and forth. This is just one tiny example. So what we have seen is, to Eric's point, where you focus on behavioral changes and lots of apps out there and people download, are these the right people? What we're finding is that, and this is something still out for debate, is that people as human beings, we're not necessarily evolved to a state where, not a lot of us, a state where we consciously worry about our health. But who worries about our health? It's the people who love us, right? Think about it. I mean, everybody who loves us, they are the people who worry about our health more than we do. So technically, if you can provide those people tools to provide and coordinate better care for me, then that may be a way to get me to be a better, healthy person. This is, one thought. But that's what we're seeing in the elder population, because lots of providers, lots of family members, they want to help the elderly live a higher quality of life. And how do they do it is with simple solutions that help them track information and then notify each other, share information, documents, whatnot, in a HIPAA-compliant manner. So that's kind of what we have seen in the healthcare industry.
Okay, I'd like to throw out a question for each of you. And the question is, how would you judge the state of public policy in this area now in terms of regulation? The Food and Drug Administration recently put out a guidance document on how it is thinking about regulating mobile medical devices. What about the state of reimbursement policy? Where are we today, any of you? Rick,
I'll start first. Okay, so, and what I'll do is I'll focus on the FDA piece, again, keeping in mind that I don't represent the FDA, but...
You don't seem to represent anyone.
Yeah,
FDA, NCI...
Why am I here? Yeah, I just drifted off the street. He grabbed me over at the donut shop, and I said, sure. One of the real strengths that FDA has, I mean, it is its ability to develop regulations. And as with any organization, sometimes things are done well and sometimes less well. I think that the current guidance that's come out related to, in particular, some of the apps that we've seen, has actually, they've done a very nice job with this. It is a fairly nuanced document. And it really makes an attempt to identify what turn out to be probably something like 95% of all health apps that they do not want to regulate. They do not feel that that falls into their parameters. So I think that they've done a nice job of presenting a sophisticated analysis of the space that we are in. And they have also begun to really put up parameters that give guidance to the kinds of things that our developers and our researchers and our startup companies do and don't need to be considering when they're moving into this space.
Yeah, and one of the, I think, two key points I want to make about the FDA as well is, number one is it at least shows it's no longer the wild, wild west. So there's a sheriff in town, there's someone there at least that developers know about. And that's important because when I initially started iMedical Ops, one of the main reasons was because I was seeing applications that were doing absolutely crazy things. There was an application that promised to treat your seasonal depression by taking your iPhone, emitting a blue light, and just shining it on your face. And so, I mean, there was crazy stuff out there. And, even today there's some questionable applications. That application got removed. But again, it at least showed that, hey, someone's here, and you can't just use some random white paper that was created by some crazy industry to back up this application. Because, again, health literacy, as Eric has mentioned, is a big issue. So, I mean, these applications you have to think about are available to hundreds of millions of people, right? I mean, just to download on their phone. So we have to, make sure that, these applications don't, cause harm. And the second thing was, I think it was great from an innovation standpoint because we were getting a lot of emails from developers and other companies saying, hey, do you guys know what's going on with the FDA? We're holding back right now on producing this application. We're unsure exactly, if we're going to have to go through the FDA or not. And actually, one other thing as well is they recognize their own limitations. They recognize, we can't regulate over 40,000 medical applications in the Apple Store, or, Android store, and that's going to be impossible to do. So we'll just give some broad guidelines. And one of the biggest things I think the differentiators is if your mobile device has leads that connect to your chest and then does an EKG or something of that sort, or it turns into a medical device, then they want to regulate it. But if you're doing health tracking or if you're doing monitoring blood pressure and other things like that, just by an application or not using a device, then that's okay.
Yeah, I'll probably touch on more on the accountable care side of things. I think what we have seen in healthcare is some significant impact, positive. Obviously, you guys have heard about it as well. I mean, historically, we have been a volume-based healthcare system, right? The more people are admitted, the more people are on CT scans, the more reimbursements. However, with the accountable care, hence the word accountable, it's value-based, right? How do we keep people away from the hospitals? How do we keep people away from getting sick in the first place, very proactive? And nobody has figured this out, but I think to your point, there is a lot of innovation going on outside to figure those pieces out. How, we've all heard of 30-day readmissions that everybody talks about. Nobody has an answer, but what a great way to start, right? Let's just start thinking about it the proper way. A lot of other things that are kind of tied to it is care coordination. Accountable care, you cannot, realistically, each patient has a lot of physicians and care providers involved, right? You cannot have an accountable care if you can't share information about that patient, right? So shared accountability has to start with shared information. And if you can share information, now you know what the podiatrist is doing, and the podiatrists know what the cardiologist is doing, and they all know what each other are doing. Hopefully, that'll avoid a lot of treatments, a lot of avoidance with respect to medication interactions, adverse effects, and better outcomes. So all in all, what we're seeing is just a fantastic way to look at healthcare. It's like 180 degrees the other way, but I think that's the way it should have been done in the first place.
I have to touch on 30-day readmission because it's a very hot topic among my physicians, especially in the ER, because it's a topic that it's a bit frustrating as well. We see, on the surface, it sounds a great idea, but at the same time...
Could you explain what the 30-day readmission
thing is? Yeah, so basically, if a patient comes back within 30 days, you're going to have reimbursement issues tied with it. So a great example is a congestive heart failure patient who's discharged, and then they come back like a week later. You're not going to be reimbursed as you would have otherwise, basically. So it's a hot topic, especially in the ER and especially with a lot of our services, because initially when it came out, physicians were just fuming because they said, well, you're telling me that this patient is going to come back, but you're not necessarily providing the support for that patient at home. So, I can send home a patient, I can send them home with, nursing care at home, and set up all this stuff, but then, in terms of Eric's, from a behavioral aspect, if that patient's going to continue taking, eating food with high salts and other things and, have another congestive heart failure exacerbation, then you're putting that on me. And that was kind of how it was looked at. I think overall it's a great idea, and but I think a better support structure needs to be tied into it.
Right, and I think you're absolutely right. So I think I'll say that that's why we're seeing a lot of care transition centers opening up everywhere, where patients, after they get discharged for congestive heart failure or acute myocardial infarction or pneumonia, those are the three things, is how do we coach these people to, number one, better adhere to their medications? Do they really know? I mean, doctors, to your point, they don't have time to sit down and have a coaching session for 2 hours. That's not how we're set up. But that's the innovation. That's where the innovation comes in. It doesn't have to be technology. It's as simple as, hey, there's a care transition center. Let's get the patient in here, teach them for 3-4 days about, hey, you got to take these yellow pills in the morning. You got to take these red pills in the afternoon. Coaching their families, right? Coaching their families about, hey, if your dad is starting to feel like heavy breathing, you better call 911. What are some of the flags in your symptoms? All those things are innovative, right? They don't necessarily technological, but they're very innovative. And that's how I think we're going to get to the point of, because when you think about doing the right thing, right things will happen, right? So,
Agreed.
And Eric, your thoughts on reimbursement?
Well, because I am no longer in clinical practice, I don't have to worry about reimbursement, so that's their problem. But I will follow up on one of the points that's being made here, and that is that, again, at a very basic level, we have an idea about how to do some of these behavioral change things. I have a family member who has Alzheimer's disease, and my coaching her to take the yellow pill in the morning is not going to be a particularly effective intervention for her. But there are technologies that could assist in this process. However, one of the things that we face in this is how do we sort out what are the tools that can really help us do this versus the toys that seem really, really cool. And so one of the challenges is somebody could present me with a piece of technology, what I would be like, wow, this is so freaking cool. This is the best ever. I then try to get my family member to use it, and it is functionally completely unhelpful to her. And so how do we sort that out? And how do we think in terms of the functionality of our technology as opposed to, oh, I invented this new technology, what can it do? Let's think about, oh, what functionality do I need to be creating? And so I guess part of this is probably me getting up on my soapbox, which is I think it is so critically important that you never forget about the core behavior that you are trying to intervene in and the function and the context of that behavior. That is what will lead you to develop devices that can address some of these very key issues about how do we keep the elderly out of assisted care? Huge challenge. Or how do we delay that anyway? How do we support this interaction between multiple doctors? How do we help the ER physician who's like, look, I did everything I could to stabilize this patient. It's not my fault that 72 hours later they're back in. So again, how do we provide support? How do we build tools that really work as opposed to getting distracted by the sparkly things?
Okay, let's open up the floor to questions and comments. There's a gentleman here. There's somebody with a microphone coming up from behind you. If you could give us your name and organization, if you can keep your questions brief so we can get to as many people as possible.
My name is Eric Shakur. I've recently retired, but I used to direct the Division of Adolescent Medicine and the University of Connecticut Children's Hospital. You're really talking about chronic disease here and methodology to deal with it. I'd like you to think about preventive directions to go. And one of the best preventive tools that I've found with adolescents is a cell phone. And beginning to think about using that kind of communication to make sure that they do show up, and if they don't show up, a relatively sure way of getting to them and really empower them to be part of the system. And hopefully eliminating your need to deal with some of the chronic disease that you're now struggling with.
I think you're touching upon something I mentioned earlier is like, if you can provide tools to people who love about a certain person and give them the tools to empower that person in some way or mechanism, whether it's text messaging or guidance or what have you, or I think that goes a long way, because now you have a unsaid like a support group, right? It's not really made as a support group, so you're not volunteering for it. You inherently feel about that loved one, and you want to make that loved one live a healthier life. So it's like a unconventional kind of support groups, just automatic. So if you can create, to your point, tools that help people to provide a reminder, other ways to manage that person, I think that's a starting point too.
And as a follow-up, I think this is an excellent example of stepping back and thinking about the behavior you want to intervene with. And in this case, what is the behavior of adolescents? So I'm not even talking about the bad choices they make, because we could spend the whole afternoon talking about that. But what are they doing right now that you could leverage to make a change in that behavior? They are text messaging. They are on social media. I should note, and this will be important for all the parents in the room, they're not necessarily on the social media that we think they're on. So there is a social media that they show us as parents. I know this because my daughter has reached an age where she finally ratted out her peers about this.
Snapchat.
Yeah.
But she was saying other people were doing it,
not
her.
her. Of course not. So where are they, and what are they doing in that space? And so I think one of the examples that has worked really well for us, so again, mostly I'm in the tobacco world, although we also do diet and physical activity. We're really moving into that. We have a very, very active Facebook site for our smoke-free women. And they are engaged in a very supportive, it's very clearly a community to support behavior change. We have repeatedly asked them to do something else in that space and completely failed. Like, we were like, a recipe contest, we'll do a recipe contest. Nothing. 0 submissions. Photos, we'll do photos. No. But what they do want to do is they do want to say, you go, girl, you're doing a great job. And they do want to say, I'm struggling with this, what have you done to fix it? So again, when we have tried to impose a function that does not fit into the behavior that is occurring on that social media platform, it has not worked. So pay attention to what they're doing. And I think, again, adolescents are a fantastic example, because we know that we can't tell them, well, what you need to do is not smoke and put down the cheeseburger. But what we can do, and so this is what drives our smoke-free teen intervention, is to empower them to make health choices. And in fact, we even say, we actually don't care what health choice you make, but we want you to make a choice.
And that's key, because you mentioned more the reminders and whatnot, and the support, and then you mentioned social media. But really, it's the fusion. So there's some pretty good there's some pretty good literature out there, especially in the pediatric populations, about kids who have liver transplants and other types of issues where they need to take their medications, and maybe before they weren't. It's not only the reminder, but it's also the support group. So if you have that support group, but it's that holistic approach, really, building in that social group, it really helps out tremendously. Which is honestly, when I was reading the literature initially, I thought that was surprising, because I thought all you really had to do was just send them text message reminders, and that was it.
Okay, other questions? Over here. There's a microphone coming over behind you.
Thank you. Rafik, MPA graduate of University of Delaware. My question is about how insurance companies approach to these changes about modernization of all application, bringing up new applications. Do they embrace these, and how, or they suspect, they approach this in a suspicion? My second question, I have also a second question. My second question is which country or countries could be a good example for food of thought, which will offer policy tools to modernize healthcare in the United States? Thank you.
I'll somewhat try to tackle the reimbursement model, because I'm very interested in that, mainly because I wonder how we can incentivize physicians to really utilize really utilize this type of technology. So I spent a lot of time with some primary care doctors, and I asked them, what prevents you from using these portals to communicate with patients? And the number one thing they told me is reimbursement. And there's some that actively do engage their patients via email and whatnot, but a lot of them just don't. There's a large insurance provider in North Carolina that will reimburse for interaction, but there are a lot of caveats with that interaction. So if the patient requires, if you come in within 7 days later with the same issue, they won't reimburse. They don't reimburse to the same level as an office visit. So a lot of physicians ask me, so what is the point? And that was actually one of the inspirations for another startup that I'm creating, which just says, forget about the insurance companies. Let's just see if patients are the ones that want to engage with their physician and actually, compensate them for that type of higher level care. But it's a huge issue. The reimbursement, because it's not up to the level of what it would be for an office visit. So what is the incentive for a physician to say, I'm going to prevent you from coming in for an office visit when I'm not going to make the same amount of reimbursement for it? It's a realistic issue that we have to deal with.
I think I can take a look at it in a different way. Instead of saying this is the technology and how payers can look at it, I think payers, their incentive is, are you providing good, higher quality of care, and is it outcomes driven based on the newer regulations and policies, right? Are you providing better outcomes? And if you do, guess what? We'll pay you, right? So when you think about that, then you have to think about what are the different technologies you can bring to the providers that help them meet that requirement. And I think that's the way to look at it. So, like, for example, I'll give you an example. In the state of Illinois, Medicare and Medicaid, they're saying, okay, we're not going to pay you, a lot of the dual eligibles that, I don't know if you guys, they're eligible for Medicare and Medicare directly, but we're going to have managed care organizations do it, right? So managed care organizations are United Healthcare, Aetna's of the world, Illini Care, all those. And they're saying, oh, in the past, government was just paying you lump sum and it was all fantastic, but now we are outcomes driven. I want to see what you're doing. I want to see if you're diabetic, have you done HbA1c test for this person? I want to see if you're congestive heart failure, for your congestive heart failure patients, are you putting them on diuretics or beta blockers and tracking them? This is what managed care organizations are requiring. So now you go to the provider side and they're like, oh my God, I got all these patients, I have no clue. Well, what about an alerting system or some type of a technology that says, if a patient has, COPD or CHF, I should be tracking certain things on a regular basis, and then provide that to my nurses, provide that to my, just caretakers or LPNs or the lower level nurses. So I think that's the way to think about it is, what is the incentive for the payers, and then how do you go around and provide providers with technology that help them meet the incentive, and then everybody starts, it's like a puzzle, it starts to fit in together.
So his second question was, which countries are doing a good job? Are there role models out there for the United States?
So I'll jump in first on this one. I really don't feel that there's any country that has successfully really scaled something up on a population level anywhere that have really taken advantage of these. However, there are a number of really nice examples of doing this well for specific problems. And ironically, and maybe it's not ironic, understandably, I think the places that have done this best have been the places that have struggled most with healthcare infrastructure. So these are going to be your low and middle income countries. We have seen some outstanding AIDS and HIV management projects coming out of Africa, being done, again, via cell phone and text messaging. We have seen some really good work in maternal and child health coming out of India. We have seen some nice work in really trying to manage chronic disease, at least in the beginning stages of this work, coming out of China, coming out of Brazil, again, coming out of India. The BRIC countries, so Brazil, Russia, India, China, are very ripe for these kinds of interventions because the penetration of the technology is so deep and the infrastructure of the healthcare system there is fragile. And so this really is the kind of environment where these technologies can play a very, very big role. And again, lots of nice projects being done in different parts of the world, but no one has really fully embraced this. But if I were going to, in fact, I'm fortunate with my colleagues at NCI to be engaged in a number of international projects. All of our projects that we're doing are in like the BRIC countries or the low and middle income countries.
So if you want to see how this is going to play out, look across the pond at the UK. Visit the website 3millionlives.co.uk. And there you'll see how the NHS over in England is really trying to, on a broad scale, trying to implement telehealth in terms of using monitoring devices to potentially improve outcomes. And right now, the implementation, they're signing up patients for it. There was a study, if you look at it, it's called the WSD telehealth trial. And that trial was a couple of years ago that showed that there was a lot of improved in outcomes using telehealth devices. So, NHS thought, okay, let's broaden this out. Let's enroll a lot of patients. And there's a lot of actually debate going on right now about, was that trial actually a good trial? Did it actually save costs? And then recently in the BMJ, the British Medical Journal, a couple months ago, they launched a trial that said, this actually is not cost effective. And then there are people that are analyzing that trial and saying, no, it's, that actually wasn't. So there's a lot of conflicting evidence, but the interesting thing is that the NHS, which is very, cost effectiveness type, about quality, effective life years, all that stuff, they're very cost effective driven. They're actually pushing forward with this. So I think really in a year or so, we'll see what the UK does with this telehealth. And I think it's the results of their research and what they're implementing on a broad scale, it's going to be very, very interesting.
I can add a little bit on the aging side. I mean, I think there are other countries around the world that are impacted by aging population much worse than U.S., Japan, Ireland, UK, to name a few. Their population is growing in masses, much faster pace than U.S. And it's a global challenge to figure out how to let people age in place and in their own environment rather than having them to provide higher level of, clinical, treatments and what have you, medications. So I think it's evolving. We're learning every day about what's going on around the world, and I think we'll figure out something, something better, hopefully.
I like your optimism on that front.
Well, and to give a shout out domestically, the Veterans Health Administration is probably the one organization, certainly the one government body within the United States that has been embracing telemedicine for the longest and really providing health care to a very large population on relatively restricted dollars. So.
But you're not speaking out on behalf of the VA.
I should note that I'm not speaking on behalf of the VA.
I want to be clear on that.
Yes, thank you.
This gentleman here has a question.
Hi, my name's Prince Saprai. I'm from University College London. I'm just visiting Georgetown Law School for the fall. So there was a time when academics used to read books, and then email came along. And now, in my job as an academic, I spend a lot of time answering emails instead of reading books. So I was just wondering whether each of you could just say something about what you think the major risks of these technologies are. What are the potential downsides? Because a lot of the discussion's been extremely positive about these things, but actually, are there downsides? So for example, one I can think of is we're talking about a lot of data sharing with people who aren't necessarily trained medical professionals, so with your family, who won't necessarily know what to do with that data. Who else is this data going to be shared with? Insurance companies. The companies that own these apps, are they going to own that data as well, and are they going to be able to pass it on? So there's a concern there about privacy, which I would have if I was going to be, which I have about these technologies, and I wonder whether or not you could elaborate on what other concerns there might be around these technologies, and also about the use of these technologies, and also what unintended consequences might flow from them.
Do you want to start first? Because you always have to go last.
Oh, okay, sure. No worries.
Good.
I think there's, what I would say is there is the privacy piece is, HIPAA covers, how do you share information? You de-identify the person. There is like certain criteria. You de-identify the data from the person, and you can share it. I mean, there's that. I think it becomes, Iltifat has more data on it. He'll share. But what we see is there is like a return, marginal returns. In finance terms, you can do so much, but at a certain point, you're not going to get any benefit out of it. So weighing the benefits of doing certain things versus not, is something that everybody has to weigh. I think there are positive negatives to everything, but the key thing is the data relevant, right? So if I'm a family member, I don't want to know all these LDL, HDLs. I just want to know cholesterol is bad, maybe, right? So it's how do you share data to the right person in the right form so they can make some sense out of it and make the right choice. So I think that's the balance.
Yeah, it's interesting. We get a lot of app developers that will come to us and tell us about some of the innovative apps they've created. Some of the more recent ones was a smoking cessation application someone developed, and patients were actually giving their personal information to this app developer, and he was using like analytics and whatnot, and he had disclaimer forms and everything, but he himself was shocked. He was like, I can't believe people are just giving this information to me, and they're like asthma applications and other things. And I don't know, I guess I'd be considered the Facebook. Facebook came out when I was, starting college, and it's one of those things where at least I feel like the younger population has kind of become an open society where they've said, I'm willing to share more information. And I think that goes hand in hand with health as well, where we're willing to be a little more open. But you're right. I mean, we're not really thinking about what is going to happen. And there are going to be incidences where data will go out in public. I know there will be. And, we're just waiting for that to happen. But it's about just making sure we do our best to be HIPAA compliant, and we do our best to make sure that doesn't happen. But even further, not even from a privacy standpoint, I'm more worried about from a litigation standpoint, just being a physician, is, as a physician, if I'm a primary care doctor and we say, all right, we're going to manage chronic diseases more from a remote standpoint. So am I comfortable just looking at blood pressure readings and having a quick 5-minute video conference with the patient, or not even having that and changing blood pressure medication? What happens if there's a negative consequence of that? Am I protected? Are we willing to do that as a society? And we've shown in our medical culture we're very, 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 very risk averse, and we'll order a lot of tests and other things because we're terrified of some of the consequences, even though we know the downstream effects aren't bad. I gave that example with the pediatric population. Just because we're getting all this data, there are downstream effects to that data that we're getting, that more testing is not necessarily good. You look at the Preventive Task Force and all that, when they come out with these guidelines that say, maybe we shouldn't be doing as much testing, or maybe we shouldn't be doing as many things. So we need to be very careful and be cognizant of the downstream effects. Be cognizant of, okay, yeah, that patient's blood pressure was going up transiently. They got one elevated blood pressure reading. They came to the ER, and now they've been waiting in the ER for 6 hours. They didn't take their blood pressure medicine. Now it's even higher. And now we have to do all these other tests. Now they've got like an inpatient admission because they didn't understand it was more a trend of blood pressures that we look at, but they were completely asymptomatic. So,
my biggest concerns are within the space of what I think we could probably call shared decision making. So there's a very strong movement in the medical field for shared decision making, and this is a very difficult and challenging process. So this idea that and a lot of the technology we develop is driven by this idea that the informed patient is better able to be actively involved in their care. And I also want to make clear that I'm not representing the shared, no. That this is a complicated space, though. I'm at the age now where the generation that is in front of me in my family are developing a number of medical problems. I have some very, very bright family members. I have a nuclear physicist in my family. My nuclear physicist family member has zero interest in making the medical decisions in his life. Very bright, data-driven guy who is like, that's why I go to the doctor, so the doctor will tell me what to do. So how do these technologies then fit into this challenge, this philosophical challenge of the nature of medicine within a shared decision-making space? And then, again, this concept of health literacy. This is a room of very, very bright people. And yet, everyone in this room, we could provide you, continuous monitoring of whatever health outcome we wanted, and very quickly, every one of us would be, I have no idea what to do with this data. So that, to me, is really the biggest risks, that we are designing tools that are making assumptions about the role that patients will play and are making assumptions about what patients can do with this data, without being too paternalistic about that comment. So.
Near the back, there's a question.
Hi, my name is Bianca Frogner. I'm a professor at George Washington University. I'd like to go back to the evaluation of apps because I think there is some desire to comment on that. I bring it up because I recently pitched an idea to the Robert Wood Johnson Foundation to develop a rapid evaluation system of apps, because I'm a researcher myself, a health economist, so I can see that the pace of doing the methods I do is too slow to keep up with the pace of the apps that are being developed. Thanks.
So you had Haptique. I don't know if you're familiar with them, right? And we, briefly talked to them as well about, how do we robustly evaluate medical applications so we can tell patients and physicians this is a good app, this is not. There's so many nuances of applications, such as, does this application crash? Does it have bugs? Is the literature right or not? We've actually submitted a few abstracts, and there's a lot of research, and this is a hot buzz. We've submitted some papers recently to journals coming up with the methodology. I can't get into too many details with it, but that's a great question, because how can you rapidly evaluate these applications? Because the biggest issue we've realized is, by the time we evaluate an application, it's updated in about 2 months. So you can't do it from an application standpoint. What you essentially have to do is tell developers, okay, if you're going to use, develop this application, you should follow some guidelines. And one of our biggest issues and gripes is people will quote medical literature, yet they won't provide a simple reference. So that's one of the things that we've been pushing a lot, is to improve the actual quality of medical applications, to tell developers, okay, you're creating this application, why don't you actually look at some of the literature out there? We'll help you look at the literature out there. And if you don't even want to do that because you don't want to go on PubMed, that's fine. But just at least put some references to where you're giving patients information and where they're going to be getting this. Because I'm not worried about the patient side of it. Because, I'm sorry, the physician side of it, I am worried about the patient side, but I'm not worried about the physician side, because physicians, I feel like, I should know when I open up an application, or if I'm using it for a drug reference tool, I should have the capability with my training now to say, okay, no, that's wrong, or that's right. I can just use it as a kind of a reference. But I'm worried about the patient side, and I don't want to act too paternalistic, but I'm worried from a health literacy standpoint that patients won't be able to make that same assessment.
So I think that what we fundamentally need to do is develop new methodologies to try to deal with this context. But I'm not representing methodologists and say, why? So in all seriousness, I think we need new models, and it's going to be complicated to do these models. One of the fundamental things that we will have to do is be able to do research in a context in which we are taking on more risk and in which we are developing and communicating subtler messages to both the public and our research participants. And so one way we might do this is that we are performing studies that have much shorter term outcomes than what we might want to do in kind of our gold standard RCT trial. So it might be that we're looking at asthma outcomes at the end of 3 months, as opposed to at the end of 2 years. Now, what we could do would be to look at it at 3 months, and then look at it at 6 months, and then see, are we even using the same technology anymore? And so it has to be this iterative process. But what that means is we're going to have to be able to somehow effectively communicate. We have evaluated this, and this is an approach that will that is more likely than not to provide an effective treatment for 3 months. We do not know beyond that. How do we communicate that to, again, to a public, well, and just as human beings, we're not good with those messages. So I think this is a great challenge, and I'm sorry you have to face this because it will affect your tenure race. But we need new methodologies, and like I said, some of those methodologies are going to involve us taking on more risk than we have traditionally been comfortable with.
Yeah, I'll throw in there's a different approach, like in vetting these apps, and not necessarily from consumer-facing perspective, but just in medicine. I'll give one example. We recently integrated with Allscripts. It's a big EMR company. They have an Allscripts developer program they call ADP. So they vet every single technology that's leveraging data, which kind of answers some of your question earlier. Like, you have all this data hidden in my EHR. How do I make meaningful use out of it in so many different ways? I think those are, again, not from a consumer standpoint, but who knows? I mean, pretty soon these EHRs have patient portals. Well, why not an app that can integrate with Allscripts, and all of a sudden you have a patient portal in an app, which is much more convenient than logging onto a website. So there are a lot of those big vendors. They're starting to take, to your point, that risk and saying, hey, we're going to open up our platform for other people to access and leverage. One of the ways we are doing, because as the patients get discharged from the hospitals into senior living communities, there's a lot of information that gets lost. So one of the reasons why we integrated with Allscripts is, like, as the patient gets discharged to a senior living community, all the information is available, right? So when the patient walks into a senior living community, everything, discharge orders, medications, automatically appear. Cuts down a lot of decision time, cuts down a lot of confusion, and hopefully better quality of care.
So Allscripts has the open API, correct?
Right.
Yeah, so they enable other companies to go in and use their data. The problem is, if you have certain companies that don't open up their APIs, my understanding is Epic, which is one of the biggest, does not, right? So I think that that's another issue, right? It's like you have integration with Allscripts, that you have certain EMRs that are not opening up their platforms. So.
Right. Well, yeah. So I mean, I think there's a movement toward it, and I think there are first movers to that, and I think Allscripts kind of fits into that. And I think others will follow suit, because look at what Apple has done with the app, right? I mean, that's an app store. You can just go in and build on that platform. It's a successful, business model. Well, some people are finding that out in healthcare. Hey, that's we have a lot of data. Let's just open it up so people can build on top of it. It makes me much stronger and more value proposition to my customers.
Fred.
Hi, I'm Fred Altman. I'm retired. And although this is a session on technology, it's clear the technology is only as good as the behaviors that are being used. And how much research is going into the behavior? What is the support or support mechanisms for the behavior to use the technology appropriately?
So within the sphere that I function, that's the primary focus of the work that we do. So I'm from the Division of Cancer Control and Population Sciences within NCI, which is the primary home of all behavioral scientists within our institute. And so our focus tends to largely be on trying to understand the behaviors, both in terms of how are people using these things, and how these things are influencing their downstream behavior. But the bottom line is that that's a tiny sliver of the research ocean, the research pie, I guess. That'd be the right metaphor, right? So, and I would love to see a lot more of that.
Yeah, I was going to say, the short answer to that is they're not enough. yeah, and that's why, Eric, the stuff that you're doing is so important. Yeah.
Mm-hmm.
Donald Barnes, South China University of Technology. There's been a lot of talk about some very exciting things that describe the relationship between the doctor and the patient, and it is a patient-focused thing. What about the larger public health issues of gathering data for epidemiology studies and looking at a broader spectrum rather than just the individual?
So the focus of the work that I do is population-based intervention work. So that's one of the reasons that it's very attractive to be in the mHealth space. And in addition to that, Heather and I at NCI have a number of colleagues who are very interested in the epidemiological perspective and how can these kinds of tools be used to, I guess you could say, take the place of our traditional, we're knocking on doors and asking you questions. So, you know, they're looking into how can these kinds of technologies be used, especially over a sustained period of time, to gather epidemiological public health data.
In the very back.
Hi, my name's Jane Allen-Amantorp. I'm a research assistant here in foreign policy. And my question is, so a lot of the technologies we've heard about are, you know, long-term monitoring, chronic care applications. But for shorter-term responses to not only natural disasters, but sort of international crises of refugees, for instance, in Syria, a lot of people affected by that are affected by chronic health issues, and a lot of deaths are a result of that. So is there anything on the market right now that's more targeted to short-term response, things like International Red Cross, that organizations like that might find of use for shorter-term responses and finding more facts on the ground? Thanks.
You do have commercial vendors, like you have company Video. It's not spelled via the traditional way, but they worked in Haiti, and they did work by, you know, they provided a platform to enable physicians here to take care of people in Haiti. And then in Syria recently, you're just using Skype. So the nice part about it is you don't necessarily have to worry about as much about HIPAA and other types of things when you're taking care of someone remotely. So plastic surgeons and other folks in Michigan, Detroit, Michigan, we're talking to people in Syria about, okay, now this is what you need to do. This is, you know, this patient requires surgery, this patient does not, and they could triage just using, you know, widely available tools. So I would say that that's one of the, I guess, the nicer things about, you know, we have existing technologies to take care of that.
So there, I'll just add something. Like we at CareMerge, we are, you know, getting requests from outside of the U.S., from Europe or South America, where people are saying, hey, can we use this in Mexico for, you know, having the patients, having the providers capture all this information and have, you know, the physicians in the U.S. provide second opinions, because there is a lack of, you know, qualified physicians in in developing countries. So I think at this point we're saying no, but I think, you know, if a technology is in the cloud, it's accessible via mobile apps, and you can capture a lot of information, take pictures, add information, and then just share it and have a chat with the other physician on the other side of the world. Why not, right? So I think I think we're going to see a lot more of that global, again, going back to the shortage of physicians, the shortage of nurses in the U.S. and around the world, but population aging globally in so many different ways. How are you going to manage that? And I think there are tools that are going to help, kind of close that gap in one way or the other by quickly accessing information at the right time, right place, and make the right choices.
Other questions?
Thank you for your comments so far. I'm Jennifer Idtree. I'm at the American Association for the Advancement of Science as a policy fellow, and I'm currently stationed with the National Science Foundation. My question is back to the preventive health end of things. So a lot of these devices are geared towards measuring chronically ill patients. But what is being done to market some of these same applications and tools to the healthy population so that we can get an understanding as to what healthy looks like, and also use that to understand when intervention is needed?
I think with that, you have an explosion of things like Fitbit and other fitness type of devices that are really, you know, marketed towards you know, patients. But again, I think one of the underlying things with that is I, in the future, foresee a time where patients will be able to use their Fitbit information, go to their doctor's office and say, hey, look, this is my weight, this is my fitness level activity, what should I improve on? You know, I have a Bluetooth, you know, wireless scale at home. you can track this and tell me what I need to improve on, you know? And I foresee a time where doctors say, okay, instead of prescribing you a blood pressure medication that you're eventually going to need if I don't do this, but I'm going to prescribe you a fitness app. Look, your weight is starting to, you know, creep up. So I'm going to prescribe an app instead of prescribing a medication. And why don't you try using this application to track your calories and other types of things, other types of activity, and let's come back in 2 to 3 months. Let's see if we made any progress. So I think a big part of it is also physicians taking ownership and saying, hey, look, these are the tools available. Let's start using them with patients before we need to, you know, start intervening and starting someone on blood pressure. Let's optimize their, you know, physical fitness. Let's optimize and at least give it a shot before we just, you know, rely on that blood pressure medication to help out.
I like that idea of prescribing an app.
Yeah, exactly. And I think that's one of the things, even out of my medical labs, that's why we were kind of looking at this and telling physicians, hey, these are the applications you can use. And when our new site relaunches, we'll be showing, we'll have a patient-specific portal where we can say, hey, look, if you're going to your doctor's office or if you want to lose weight, this is what you do. But these are the applications you can use. But also for a physician side that says, you know, you don't know much about technology, that's fine. But here are a couple applications you can get your patients using, and here's how you can interpret that data. I think that's important. But again, for physicians, you know, there has to be that incentive to say, yeah, you know, my patient emailed me their Fitbit information, and I evaluated and reviewed it, and you know, this is how I'm making, you know, change. These are the suggestions I had for them. There has to be some sort of incentive to do that.
Yeah, it's a very it's a great question, actually, because I think if we can answer that, we'll have a lot of you know, better health across the board. I think clinical is one aspect of it, but it's really driven by lifestyles, right? How did I grow up? Where did I grow up? What I used to eat? Did I used to eat a lot of donuts, or did I eat you know, good whole wheat bread? I don't know. And then socially, which places? So there's so many elements to it that you can, you know, I think it just seems like impossible to kind of figure out what is the right recipe for it. What we have tried to do, you know, is in elderly population, it's easier to do because they're in a place where the providers are required by law and regulations to track all those lifestyle choices. So are you eating your breakfast or you're not? Are you going to play Scrabble or not? How active you are in a community? How many off-site visits you go to? How is your skin look like? And there's all kinds of regulations and assessments that these people have to do and the providers have to do, so which helps us, at least in that kind of mode where providers capturing this information on a daily basis for about every single elderly, and then out comes a great trending capability that now we can use to say, hey, wait a second, this person has just stopped eating or slowed down eating his favorite, meal, which is very healthy. What's going on? Which is very hard to do if you look at from a consumer's perspective, because nobody wants to keep track of it unless Fitbit comes up with something like every single different pieces that's like we're consuming, and it just brings all those pieces together. Then I think it'll be just fantastic.
So the primary focus of the work that I do is on health behaviors in people who are theoretically otherwise healthy. So we really fundamentally are prevention-oriented. You did bring up a really interesting point, though, that was, is there a way to use this data so that we can better define what health is? And I don't know the answer to that. I know I'm being very helpful on this panel today, right? So, but you talked about if we were tracking a large group of people across time and we began to see changes in values of whatever we think is the appropriate biomarker, does that then become something that allows us to make a prediction about an elevated disease risk as that has changed over time? That would be, and I could foresee that happening, that would be an amazing step forward in the biomedical sciences.
And Eric mentioned a lot of the people that are using this data and aren't necessarily the ones that are the ones we're worried about. The people using Fitbit and other things. That's why I think it needs to come more from a provider-centric approach, saying, hey, you're at risk. I'm going to talk to your insurance company. They're going to reimburse you the $10 for the application that you downloaded that I prescribed to you. And then we're going to have a chat about how you're using this application and how you're using it to monitor your health. It's a calorie counter, et cetera, et cetera. So, I think that's the key. It's not necessarily the people who are using it, which is great because the people using it right now are kind of, allowing us to experiment and figure out how to best capture this data. But I think in the future, from a healthcare organizational standpoint, or even insurance companies getting involved and saying, and they are right now already, insurance companies are creating applications for better healthy living and whatnot. It makes sense to them. So, yeah.
Okay, we have a question up front here.
Hi, I'm Rachel Rogers. I'm with Newswire Agence France Presse. And I wanted to ask you, it sounds like things are happening a lot faster. We can talk to people all over the world on Skype, whereas before we'd have to send them a letter or something. But I'm also hearing about a lot of problems that it seems to me have existed for a long time, getting people to actually change their behavior. Even if you get the doctors to prescribe these apps, are people going to use them? And so I'm wondering about how to qualify how effective they're being, because a lot of these issues are, we've got all this data, but are we seeing changes? Are we seeing, these positive results that we could be?
Outstanding question, and yeah.
The jury's
so
yeah,
it's kind of like, one of the problems is I'm reminded of back when I was an undergraduate, the university professor said, this would be a really great university if we didn't have all these damn students here. And that's kind of the space we're in here. It's like, we could do so much cool stuff if we didn't have to deal with human beings in that. And so I feel like one of the things we have to constantly come back to is recognizing the fundamental behavior of people. And this wonderful idea that if you build it, nobody will come. And so we have to think about, and so this would actually be kind of, I know we're running a little short on time, but kind of my parting plea to you is to think about how you can use the functionality within your technology to more effectively engage what in my case are, patients. That's the group I'm with. How can you use that technology to more effectively engage them in your technology? And a closely related issue to that is to be thinking about how can you get them to use that technology over an extended period of time such that it would be more effective. It's so clear from, you could pick any clinical intervention you want, and what it comes down to is if you can actually get people to do the intervention, then the treatment group does really great. But a huge chunk of our clinical trials, both in the treatment arm and the control arm, are non-compliers. And we never calculate that in to our analysis, and that's a real problem. So basically it's like, so I'm a clinical psychologist. If you will come to my office once a week for, pick a time period, 3 months, I can help you. Am I going to do anything amazing? No, you're just going to actually come to my office. And just the very fact that you're the kind of person who would come to my office makes it that you are more likely to get better. So again, how do we can't forget these fundamental human behaviors in this technology.
Yeah, this is my problem. I'm still waiting for the app that will do exercise for me.
There you go. That's what I need, yeah.
It's coming in about a year.
A little app, it's like it goes off on your bed and you hit it at 5 o'clock in the morning and it runs off and it runs a couple miles for you. Yeah, yeah.
My thought is going back to, I think we care more about our people we love than ourselves. And that's, if I think there's some thought process needs to, because what we're seeing is if people love somebody, they care about them and they're going to make the right choices for them or help them. But as human beings, we're just stubborn people. We just don't care about our health. We just go along unless something happens. I'm not going to go see a doctor, no matter how educated you are, no matter how well educated you are, or whether you're from one field or the other. It really boils down to human beings that just don't care about themselves as much as their wife or their kids or somebody else. And that's the inherent love actually tries to push, like my wife pushes me to run every single day. And I'm like, So I actually do that because of her. But if it's up to me, guess what? I will never do it.
And you call that love?
Tough love, right?
I don't think there's one magic bullet. I think it's just a holistic approach, kind of what we talked about before. I think these tools kind of help out, but if you look at the literature, again, it shows that you need that holistic approach. You need the social media aspect. The peer pressure aspect is absolutely amazing. I'm sure you've seen this as well, but you need kind of that peer pressure aspect. You can use technology to help do that. And use technology to remind people to do things. But again, there's certain things that are just very hard. You know, the way people are, I'm from Winston-Salem, so, well, that's where at Wake Forest, that's where I'm training, but we, see a lot of obesity, we see a lot of other things. I mean, the folks, they're, it's how can I change that person's behavior, the way they're raised, the culture they're around, they don't know a smartphone. It's hard. How do you reach those patients? And that's a lot of the stuff that you're working on as well. Text messaging and other types of things. But it has to be this very broad, holistic approach. The technology is cool, but it's not going to be the magic bullet.
Oh.
And I'll put in one more plug, and then there'll probably be one more after that too. But when we're thinking about fundamental human behavior, we have to think about what is motivating behavior, and we have a very good science that demonstrates that there are certain kinds of motivations that are super awesome good for short-term change in behavior, but they don't work in the long term. And we also know we can prime certain behaviors that are much more likely to sustain those. And so I think we really do have to be giving careful thought to what are we doing within our technology that is helping to develop sustainable health behavior change.
I'll just add one last thing to it. It just occurred to me. I mean, we've actually seen some behaviors change if you give them incentives, right? I mean, that's one thing we all know. And there are lots of employers who have self-insured. They've started to provide these policies to say, hey, if you reduce your cholesterol level to this, guess what? Cha-ching, there's $500 for you there. If you reduce your waistline by 2 inches, then there's this reward waiting for you. And we are seeing that again and again. I think it's been very successful in a lot of organizations.
This is actually the classic challenge we face, that incentives are super good at these short-term changes, but we need a different approach for long-term changes.
And education, right, is so key, because even in the ER, I always look at it as teachable moments for my patients, and I'll ask them, I'm very blunt about it. Patients will come and say, even if it's not related to why they're there, I'll say, what are you doing about your weight? And a lot of times, well, I don't have a primary care doctor, I'm not. And I'll ask them, very briefly, this takes literally about a minute for me to do, and I'll say, what types of food do you eat? Okay, do you go out? Do you eat fast foods? And they're like, yes, I do. And I'll just pull up an app, I'll show them the calories that they're getting from their fast food. They're shocked. Wow, I didn't know it was. And it's very simple things that we take for granted, and we assume that everyone knows, but hasn't necessarily been taught to them. That, hey, you reduce, soda intake, you can lose several pounds, and things of that nature. I think education is a really big part of it.
I mean, I do think these incentives are very important, but I'm reminded of the story about Warren Buffett and his son, who is overweight. And this is a true story. So Warren basically offered his son several $100,000 if he would lose a certain number of pounds. The son could not do it. So there are some limits to incentives.
Yes.
But I want to thank, we're out of time, so I want to thank Eric and Iltifat and Asif for sharing your views with us. Thank you very much.
All right, thank you.